I will start my presentation by this short case. This is a 40-year-old man presents to the emergency department with acute loin pain and hematuria. He has no previous similar attacks. He takes some antihypertensive medications for his chronic hypertension. His physical examination is remarkable only for light flank pain and tenderness, with no other positive signs or symptoms. The patient is admitted for pain control. Kidney stone, ureteric kidney stone was suspected, and the workup for kidney stones during this current admission was done. The question now, the workup for kidney stone detection or diagnosis during this current admission for this patient should include all the following except what? Serum uric acid, serum phosphate, urine microscopy, non-contrast CT abdomen and pelvis, 24-hour urine stone risk profile. I will go through my lecture, then I will go back to this case presentation. So this is my talk outline. I start by diagnostic imaging. What are the first-line diagnostic imaging procedures that should be used in patients presented or present with clinical manifestations of kidney stone? For sure, the first line of imaging is low-dose non-contrast CT. It is better to be done within 24 hours of the clinical presentation of the acute attack. And for sure, if the patient is a pregnant woman, we cannot use non-contrast CT, so we have to offer ultrasound instead. Regarding plain abdominal X-ray, does it have any role in diagnosing? The answer is no, but it may have a role in follow-up of the kidney stone, especially if the patient has documented radio-opaque stones. So plain abdominal X-ray imaging can be used to assessing stone clearance, recurrence, or growth, because for sure the radiation exposure in the X-ray will be less than the non-contrast CT. It is important point to mention that we have to manage the pain in this patient, especially if the ultrasound, the CT imaging will be delayed. So pain relief or any other emergency measures shouldn't be delayed by imaging assessments if it is not available yet. So start your medical management to control the pain till the patient can have his or her imaging assessment. So the next line is, after diagnostic imaging, what is the management of acute symptomatic stone attack? As the patient I presented, the flow chart for the management of symptomatic stone, first of all, does the patient has uncontrolled pain, vomiting, fever, or hydronephrosis? If the answer is yes, so consider to admit the patient in the hospital. If no, the patient can be managed as outpatient. If the patient has these severe symptoms, if there is fever, acute attack, acute kidney injury or anuria, for sure urgent urology evaluation for the possibility of obstruction and the possibility of PCN. If no, there is no fever, acute kidney injury or anuria, and from the start, the other option, if there is no uncontrolled pain, vomiting, fever, or hydronephrosis from the start, so the management will depend on the stone size. If the stone is less than 5 millimeters, there is a high chance for stone to spontaneously pass. So the treatment here will be just supportive treatment, hydration, and strain urine. I will explain more what is strain urine in the coming slides. If the stone is between 5 and 10 millimeters, there is a possibility 50% of the stone to pass. So the management here will be supportive care, hydration, medical expulsive therapy, especially for the distal stones in the lower third of the ureter, especially alpha blockers. There are a lot of medical expulsive therapies that can be used. The first line always is alpha blocker. If alpha blocker is contraindicated for any reason, we can use calcium channel blockers. This is less commonly used, but can be used if alpha blockers are contraindicated, example for nifedipine. And also corticosteroids maybe have role, especially in distal stones, especially if the stone is impacted and causing edema at the ureteric orifice. Me, myself, I had a ureteric stone before, and it was impacted at the ureteric orifice, causing edema. And it didn't pass down except after I took corticosteroids. So corticosteroids is an optional management that can be used if there is edema in the orifice to resolve this edema and facilitate the passage of the stone. If the stone is more than 10 millimeters, its spontaneous passing is very low. The chance is very low, less than or approximately 25%. Urology evaluation is mandatory with this strain urine. So what are the preferred analgesics that must be used to control pain? For sure, the first is non-steroidal. But if non-steroidals are contraindicated, intravenous paracetamol can be used. If non-steroidals are contraindicated or non-steroidals didn't give sufficient pain relief. And the last line can be used is opioids if both non-steroidals and intravenous paracetamols are contraindicated or are not giving sufficient pain. Just to mention that it is not preferred to offer antispasmodics in patients with renal colic. Why? Because actually they didn't show, there is lack of evidence. There is lack of evidence of their use. And as you know, the pain in the acute attack of kidney stone, mainly it is not due to smooth muscle spasm. It is due to mainly the pressure that is caused by the obstruction of the kidney stone itself. So the pain in the acute renal colic is not spasm of the muscle like the gastrointestinal or biliary tract spasm, but it is mainly due to the high pressure that is caused in the renal collecting system and the ureter due to the obstruction by the kidney stone. So there is no role for antispasmodics to treat suspected renal stone in adults, children, and young people. What is strain urine? Strain urine or straining urine means filtering urine using a fine mesh like this. This fine mesh to catch any kidney stones, the urine must be filtered through it to catch any kidney stone passed from the patient. And for sure, this stone collection is important for formal compositional analysis to know the type of the stone, to direct the medical treatment to be more effective according to the type of the stone. The next point I have to mention, we treated the acute attack of pain in the patient. What are the basic laboratory analysis that I have to do after I treated my patients? And is there any rule for surgical treatment in this patient? I will start what are the indications of surgical treatment in patients with acute attack of kidney stones. Offer surgical treatment for patients or to adults with ureteric stone and renal colic within 48 hours of diagnosis or readmission if any of the following are present. First, if pain is ongoing and not tolerated, or the stone is unlikely to pass, especially if its size is more than 10 millimeter. What are the basic laboratory analyses that I have to do for my patient with acute kidney stones? First, urine analysis, the formal dipstick urine analysis to detect if there is white cells, red cells, nitrites, infection, or whatever. The second, blood tests. What are the basic blood tests? For sure, creatinine, uric acid, ionized calcium, sodium, potassium, blood count, and C-reactive protein. Finally, if the patient is going to do an intervention from the urologist, for sure we have to do a coagulation profile for this patient and maybe bleeding profile in this patient too. A 24-hour urinary collection to collect the urine of the patient to know its chemistry. To collection, if possible, is the cornerstone of evaluation in patient, but this is in recurrent kidney stones. And the recurrence of kidney stones will be discussed by Dr. Sumaya. I will not go in depth in it, but I want just to highlight that if it is a first attack of kidney stones, there is no need to make a 24-hour urine collection, but it is mandatory to make a 24-hour urine collection if the kidney stone is recurrent in this patient. So back to my patient. What do you think? Which of these clinical investigations shouldn't be done? The answer here is 24-hour urine stone risk formation. We are not in need to do in this patient. Why? Because the patient has had no previous similar attacks, this first attack, so we can postpone this, but for sure we have to do serum uric acid, serum phosphate, urine microscopy, non-contrast CT, abdomen and pelvis. After I mentioned or discussed the management of acute symptomatic stone, what about asymptomatic kidney stones? Regarding asymptomatic kidney stones, it's better to consider watchful waiting for asymptomatic renal stones in adults, children, and young adults if you can watch the stone without intervention, without surgery, without as well, if the stone is less than 5 millimeter and it is asymptomatic. But if the stone is larger than 5 millimeter, you can also wait, but in specific situation, after an informed discussion of the possible risks and benefits. Because if the stone is larger than 5 millimeter, the possibility of complications regarding infection, regarding obstruction and the hydronephrosis is more. So if it is larger than 5 millimeter and the patient preferred just watching and supportive treatment, you can do this after informed discussion of the possible risks and benefits with the patients. And for sure, don't forget also to do the basic laboratory analysis that I mentioned before. Even the kidney stone is asymptomatic, to diagnose the predisposing risk factors that develop these kidney stones and to treat it, as I will mention now. What are the medical management lines that I have used in both patients with acute attack of symptomatic stone and patients with asymptomatic stone. In the patient with acute attack with symptomatic pain, we treated the pain, as I mentioned, but what is next? What are the medical management lines that I have to do next? And the same lines I can use in the management of asymptomatic stone. I will not go in more details in these lines, because also Dr. Sumaya may cover most of them, but I will go through them rapidly. This is the general lines or steps for management of kidney stones. I will highlight some of them. First of all, you have to treat underlying condition. A very large list of underlying conditions that may cause kidney stones, you have to search for them, and if any of them are present, you have to treat. For sure, you have to do a dietary assessment and increase urinary volume. The patient must increase the water intake, maybe adding fresh lemon juice to drinking water. The patient must avoid carbonated drinks. The patient must decrease salt intake. There is no need to restrict calcium intake in these patients. This is maybe a type of malpractice. Many doctors or physicians may restrict calcium intake, especially one of the most common stones that are formed are calcium oxalate stones. There is no need to restrict daily calcium intake, but maintain normal calcium intake, because we all know also that over intake of calcium may cause nephrocalcinosis. And we have a lot, I saw a lot of patients who are going to the gym. They are bodybuilders and they're taking a lot of vitamin D and a lot of calcium supplements. And they came to me to the clinic by nephrocalcinosis. So no rule for restriction of calcium intake, but again, no rule for increasing the calcium. I have to tell my patient to take the daily requirements of calcium depending on his or her age. I can use treatment. I will not go through the medical treatment. I'm sorry to give the space for Dr. Sumaya to mention, but we all know that we can use some medical treatments according to type of stones. And I have to just mention a recently published paper, because you know that SGLT2 inhibitors are involved now in everything in nephrology. SGLT2, the evidence is saying it is a magic. I am bit sure that in the coming future, they will make a study approving that nephrologists themselves must take SGLT2 inhibitors, for the sake of their patients. This is a recent trial showing that patients that are on SGLT2 inhibitors have lower risk of kidney stone in comparison to patients who are diabetic or not diabetic on placebo or other active control. So it seems by evidence that SGLT2 inhibitors in general is protective against kidney stones. Regarding surgical treatment, I am not a surgeon, so I will not go in depth, but I will just the indications of surgical treatment of kidney stones. Indications of active stone removal. First, when I have to do surgery for this patient. If the rate of stone growth is very rapid or high, the stone is in high-risk patient. For example, the patient is already has hyperuricemia, the patient has hyperuricemia, whatever the risk that may precipitate the formation of kidney stone. So if the patient is already a high-risk patient for formation of kidney stone, the stone must be removed. Obstruction caused by stones. The stone must be removed to relieve this obstruction and hydronephrosis, especially if the kidney is functioning well. We met a lot of patients who has kidney stones in the ureter, accidentally discovered with deep pain. They had hydronephrosis. The key to do surgery or not in this patient, the shape of the kidney in the ultrasound and in the imaging. If the parenchyma is well, the size of the parenchyma is good, the corticomedullary differentiation is good, so this kidney is healthy, so we have to do the surgery to relieve the obstruction. But if the kidney parenchyma is very thin, poor shaped kidney. In this situation, we may prefer not to go to surgery for the risk of anesthesia, especially if the function of this kidney, as I has mentioned, is totally lost, and there may be no benefit from relieving this stone. When, again, to remove kidney stone, for sure if there is infection, if it is causing infection, pain and hematuria, according to the approach that I mentioned at the beginning of my lecture. If the stone is large in size, if the stone is small in size, as I mentioned, and the patient is refusing the option of observation, we can remove it. Patient preference overall, and comorbidity. And one of the most important points to, or one of the most indications from my side regarding the removal of kidney stones, the lifestyle of the patient. If the patient has a symptomatic kidney stone, but he is making a lot of travels from country to country, it is preferred to remove the kidney stones, because it will be a disaster if he has a renal colic in the aeroplane. Social situation of the, this is the one I'm talking about. If he is traveling a lot, or if his profession is not preferred to leave the kidney stone in its place. This is the different surgical approaches for removal of kidney stones. I will not go through them, but I will mention that they selected their approach according to the stone size and location. They choose between PCNL, SWL, endourology, whatever, but their choose mainly, or their selection mainly, it depends on the kidney stone size and location. So finally, my home messages, but before I say my home message, I have two notifications. The first, as I am the chair of Afran Web and Media Committee, I am inviting all of you to visit the Afran website and all the channels of Afran Web and Media Committee to follow all the activities of Afran. You can see here, if you take a screenshot of this, the Afran website, the Afran group on Facebook, the Afran page on Facebook, Afran YouTube channel, where we will find the video records of all the webinars of Afran in both English and French, and the Afran X account. And the second notification I want to mention, I am inviting you to visit my own website, educational nephrology website, nephrotube.com. You will find on it 110 videos explaining nephrology. You will find on it I had published 2 nephrology books, one about hemodialysis and one about glomerular disease. You will find them. And you will find a direct link to the YouTube channel where I am discussing most of the nephrology topics in both English and Arabic. No French, I'm sorry. Je ne parle pas français, okay? Regarding my home messages, first, start with non-contrast CT for diagnosis. It is the gold standard. Second, don't delay pain control for imaging. Attempt stone collection in all patients is mandatory for formal compositional analysis, crucial for future prevention. A 24-hour urine study is key, but only in recurrent kidney stone formers. Basic lab workup must be done in all patients. First attack, recurrent attacks, whatever. The patient had a kidney stone, basic lab workup must be done. Medical management should be tailorized according to the stone type. Refer to urology early in patients with infection, obstruction, solitary kidney, or failure of medical therapy. And finally, tailor surgical intervention based on stone size and location. Thank you for your interest.